healthcare in our communities for a long time. Before I want to share some comments, and before I get started on that, I just want to offer a couple of thoughts, and that is that I'd ask that everybody please put all of your devices, computers, tablets, etc. on mute. The presentation itself will last approximately 45 minutes, maybe a little bit longer, in the midst of which we will have one breakout session in which we're going to be asking you to reflect on a particular question. We also would offer that if you have questions or comments that you'd like to make, please offer them in the chat function on your computer or your tablet. I will collect them, and then after our presenters have finished with their talks, I will be glad to convey that information to them and offer to them for responses. If you're having trouble during the presentation itself with some concepts that are just not making any sense, make a statement to that effect, and both of our speakers have offered to clarify that. Yes, in the chat, please. But they also offered to clarify if need be. As many of you know, I know a lot of the names and faces here. I'm a retired family physician, and the work that we're going to be talking about tonight is something that was always present for me throughout most of my career. And I recognized what was going on a lot of times, but why it was going on was a mystery. And it wasn't until late in my career that the concept of social determinants of health became a part of it. Early, when I was younger as a physician, I worked for 2 years at an Indian Health Service physician on a reservation in rural Nebraska. And while I was there, I saw a lot of the effects of poverty and depression, alcoholism, cultural dislocation. They all affected these people's health. And it was something I was able to observe but didn't understand. A few years later, as I came to Hastings, I actually saw the same kind of things, but with a different kind of expression. I saw seniors who were putting off their own health care until they could get coverage by Medicare. I saw young families trying to make decisions about whether children should get their health care or their parents should get health care, but they couldn't afford both. I saw immigrants who were non-native English speakers struggle to get adequate health care because their culture and language and my culture and language were different, and we had a difficult time connecting and understanding each other. And you know, in the last year, both in this country and globally, we've seen the effects of COVID-19 on the burdens of disease and mortality in populations of color and populations in poverty, and for those who don't have adequate access to care, and even for those who have been what we've designated as essential workers, who've been providing services to those who've had the privilege, like I have, of either sheltering or working from home. And all these disparate experiences, socially, behaviorally, economically, have an impact on people's health. Tonight, I'm delighted to introduce our two speakers, who both are researchers from the University of Minnesota, who have dedicated a substantial portion of their career to thinking, learning, writing, and teaching about these issues of healthcare disparities. Dr. Susan Everson Rose is a professor in the Department of Medicine, the Associate Director for Research in the Division of General Internal Medicine, the Associate Director of the Program in Health Disparities Research, and Director of the Health Equity Leadership and Mentoring Program at the University of Minnesota. Dr. Everson Rose's research has shown how stress, distress, emotions, personality, behavioral, and socioeconomic factors contribute to an increased morbidity and mortality for a number of diseases. It contributes to greater cognitive decline and to worse health outcomes in general. She has been an NIH-funded investigator for over 25 years, is an associate editor for a peer-reviewed journal called Psychosomatic Medicine, and is nationally and internationally regarded for her work on psychosocial risk factors for chronic diseases. Dr. Elizabeth Rogers is an assistant professor in internal medicine and pediatrics, also at the University of Minnesota, and has an appointment in the Applied Clinical Research Program. She is board certified in both internal medicine and pediatrics and is a graduate of the University of Nebraska College of Medicine. After finishing a residency at the Brigham and Women's Hospital in Boston and the Boston and Children's Hospital, she completed a primary care research fellowship at the University of California in San Francisco. Her interests include socioeconomic and ethnicity-based disparities, and especially as it has an impact on chronic disease. She's also interested in supporting patients in prevention and management of these chronic diseases, health coaching and peer education, implementation science, and community-engaged research. Please welcome Dr. Zeverson Rose and Dr. Rogers, and I look forward to hearing your comments. Thank you.
Thank you, Bill. It's a pleasure to be here.
Yeah, thank you so much. Let me share my screen.
So Beth is going to be in charge of slides. So if you have trouble seeing slides, it's her fault, not mine.
Oops, hold on. Let me try it one more time. For some reason.
Yeah, from the beginning, right?
Working, yeah. Are you seeing?
Yes, we're seeing it.
Yeah, can you go to the slideshow view?
I know I'm, hold on. Sorry about that. How's this?
Got it.
Yeah.
That's
Wonderful.
great.
All right, thank you for your patience.
Okay, well, it's a pleasure to be here tonight. Beth and I have had a lot of fun putting this presentation together and kind of putting our heads together and sharing our experiences. As Bill mentioned, I'm a professor in the Department of Medicine. I'm a researcher, though, by training. I'm a psychologist and an epidemiologist, so I'm very data-driven. And while I'm a people-oriented person, I am not a clinician. And so Beth is a clinician and brings that expertise. So I think between the two of us, we can share slightly different perspectives on this topic. We are also both faculty members in what is called the Program in Health Disparities Research at the University of Minnesota Medical School. I think you can go to the next slide, Beth. So the mission of PHDR, as we call it, is to promote health equity through collaborative research, innovative education, and trusted partnerships. And our vision is to eliminate health inequities in Minnesota and beyond. Our program was founded in March of 2006. And so we are actually have just wrapped up our 15th year. It's kind of hard to believe. And I've been there for nearly all of them, not quite all of them. Do you want to go to the next slide? So the work of PHDR is guided by 3 operating values. And I wanted to take just a minute or two to go through this so you understand the framework that we're coming from. So one of the values that guides our work is social justice and racial equity. We really seek to create systems change that centers and champions diverse and marginalized perspectives. So we have a deep commitment to social justice and racial equity, and it guides our decisions regarding hiring, programs, activities, partnerships, and importantly, budget priorities. You may have heard the phrase, don't tell me your values, show me your budget. And so we let that be our guiding principle to the extent possible at the university. We also have community-centered partnerships. Communities really are at the center of what we do. We try to nurture equitable and mutually beneficial community-driven and community-centered collaborations that are based on integrity, authenticity, transparency, and fairness. We really want to know what communities care about, what problems are important to them, and work with them to help find solutions to those problems rather than sit in our ivory tower, as it's called, and try and drive solutions to communities. We also really focus on translating community knowledge into action. We want to have an action-oriented work. We believe that community expertise and knowledge are in fact essential to eliminating health disparities. So through our collaborative work and dissemination, we try to co-produce knowledge and generate meaningful action to advance health equity. So that's really the values-based perspective that we take. Next slide. So we have a couple of learning objectives. We hope to define, by the end of tonight, you'll be able to define and understand social determinants of health. The acronym is SDOH, and identify ways that these social determinants can influence chronic diseases and COVID-19. So we'll give some examples. As Bill mentioned, we'll have a breakout about midway through, come back together and continue some more conversation, and then have plenty of time for Q&A at the end. But again, if anything's unclear, something really pops into your mind as we're speaking, go ahead and throw it into the chat and Bill will be monitoring that for us. Okay, so I think we can get started. I thought it would be useful actually to define some terms at the outset so we're all on the same page. Being in the medical school, we use these terms, Beth and I use these terms all the time, but we recognize that they can be unclear or confusing if they're not part of your everyday language. So by cardiovascular diseases, which you'll see the abbreviation CVD, we're talking about high blood pressure or hypertension, coronary heart disease, myocardial infarction, which is also shortened as MI or commonly called heart attack, angina, which is chest pain upon exertion, and stroke and heart failure. Now, there are other types of heart disease or cardiovascular diseases like congenital heart diseases. We won't be talking about those today. Prevalence and incidence are two words that often get mixed up and are often used in the work that we do. So prevalence is the estimate of how many people have a particular disease or a risk factor at a given point in time. Whereas incidence refers to the number of new cases of disease that occur in a population over a specified period of time. So you can have, prevalent hypertension now in March of 2021, or you can look at how many new cases of hypertension develop over the course of calendar year 2021. So that's the distinction. Morbidity and mortality are two other words that often get confused but are commonly used. Morbidity just generally refers to disease states, having the medical condition or disease of interest. Some people think about it as kind of the suffering or the sickness that people experience with the condition. And mortality quite simply refers to the deaths. It's compiled from death certificates which state health agencies report to the National Center for Health Statistics. So those are national data. Death rates are a ratio between mortality and population. So you want to compare among populations or across a time adjusted for the age of the population, you look at rates. And then health disparities we define as population-specific differences in health status. And the populations are typically defined by demographic characteristics or what we could typically consider demographic characteristics, for example, sex, race, ethnicity, socioeconomic position or socioeconomic status, and geography. So just a quick primer on those words, and please feel free to ask questions if they get confusing. Okay, so I'm going to start by talking a little bit about the burden of cardiovascular disease in the US. And so what this slide shows you is, and I'll go through the bars so it's understandable, hopefully, that nearly half of Americans that are 20 and older have at least one type of cardiovascular disease. And prevalence does vary by sex and by race, ethnicity. And so if you look at, prevalence of coronary heart disease, heart failure, stroke, and include hypertension in the count, that's when you see that 49.2% of all Americans 20 and older have at least one of those conditions. And so in this slide, if you look at the taller bars, they're organized. The blue bars are representing men and the red bars are representing women. And then across the bottom or the x-axis, we have groupings of people. So non-Hispanic, NH stands for non-Hispanic, non-Hispanic white, non-Hispanic black, Hispanic, and non-Hispanic Asian. And Asian does group together in this slide people with a variety of Asian backgrounds. So that can include Chinese descent, Japanese descent, South Asian, Asian and Pacific Islanders. One of the things that happens when you look at the data is we have fairly rigorous data for people who identify as white, who identify as black, and for who identify as Hispanic. Some of the other data for various groups can be hit or miss. So just a word of warning about that. But what you see here, in each case, across the racial and ethnic categories, men have slightly higher prevalence of cardiovascular diseases than women. Now, the shorter bars are when you exclude hypertension from the definition. So it's looking at people who have coronary heart disease, heart failure, or stroke. And so what this tells you is that the shorter bars, because they're so much shorter than the taller bars, that hypertension is a huge problem in the US, okay? But you still see that there are, with one exception, the men have higher rates than women, and the lowest rates are amongst those who identify as Asian, and the highest rates are amongst those who identify as Black. So it's showing this high burden of disease, but different patterns. Okay, the next slide. This slide also shows health disparities in cardiovascular diseases. And what it is graphing are the annual numbers of heart attacks or fatal coronary heart disease. Typically, when someone has a heart attack, it's classified as either fatal or non-fatal. So this slide is grouping those together. And it's from a nationally representative sample of US Blacks and whites called the ERIC study. And it's data averaged or collected over 10 years. And so it's an annual average. So what the slide tells you, the red line that goes across the slide represents Black men. The orange line right beneath it is Black women. The darker blue line beneath that is white men. And the lighter blue line on the bottom is white women. And so across all age categories, we have, from 35 to 44, 45 to 54, on up to 75 to 84 in this particular study. What you see is that the Black men do the worst at each age group. And if anything, the differences between the Black men and the white men gets wider over time. So I guess I don't have any kind of cursor to point this out, but hopefully you're following along. You see that it's really graphing, the number per 1,000 people, and the value in the 75 to 84-year-old group for the Black men is up to 20. Thank you, Beth. Whereas you can see for white women, it's right below 10. So a doubling of the numbers of Black men who are burdened with heart attack and fatal coronary heart disease. So really stark disparities. We see similar patterns with diabetes. Nearly 27 million people in the US had diagnosed diabetes in 2018, and that's about 8% of the population. And so this too shows the pattern by race, ethnicity. And in this case, we have a little bit more data. So we do have separate data on American Indian and Alaska Native individuals. And so what you see is that the purple bars, which represent men, are mostly, but not completely, taller in each group. But you see this different pattern across the different racial ethnic groups. So you see the bars are lowest amongst those who identify as Asian, who are non-Hispanic, but highest among the American Indian, Alaska Native, and the Hispanic group, also very low amongst the white and non-Hispanic groups. So the point of the slide is really to point out that while the overall prevalence is 8%, it really varies, right? It's double that amongst American Indian and Alaska Natives, double the national average. So you see these stark differences across groups. So you have to start thinking, why is that, right? Another way to look at that is to really talk about life expectancy in the US. Now, life expectancy reflects the overall mortality level in a population, and what it's calculated as is the average number of years that a newborn baby could expect to live if the current rates continued. So a baby born, in 2018, in which the average life expectancy was just under 79 years, would be expect to have a life that went that long. Now I've put a picture on the slide to give you a clue as to which state might be doing the best, because while the US average is 78.7 years, that is an average, right? And so it's different across different states. Go to the next slide, Beth. So this shows life expectancy in the US by state. And the picture, you might have guessed, was Hawaii. And so it has the highest life expectancy in the US. In 2018, it was 82.3 years. And that's shown towards the bottom of the slide. The darker green colors represent states that have life expectancy above 81 years. So you see that California has 81.6 and New York has 81.3. Minnesota comes in fourth. We're at 80.9. West Virginia has the lowest life expectancy at 74.8 years. So you see this range, these state averages, it ranges from almost 75 to over 82. So it's about a 7-year range. Colorado, which is shown in the same color green as Minnesota, is at 80.5. And South Dakota, which is a lighter shade of green, but just a neighbor to us, of course, is 79.1. Again, these are state averages. But if you dig a little deeper, this is actually a map where the life expectancy is mapped out by county. So you still see that pattern, right? So the darker red is the lower life expectancy. And so you still see that pattern in, as you head towards the southeastern part of the US, with the greener areas up near where we are, and also some in the Northeast. And you see lots of different colors in Alaska. So what this slide tells you is how important it is to kind of dig down into the data. And in fact, next slide, Beth. What's really interesting is the county with the highest life expectancy is actually San Miguel County in Colorado. I'm not sure how well you can see the arrow, but it's the county where Telluride is. Thank you, Beth. So it's this little green sliver. So the average in Colorado, as I mentioned, is 80.5 years, but this county in Colorado is 20 years more than that. And the US county with the lowest life expectancy is Buffalo County, South Dakota. That little dark maroon along the Missouri River. And that is actually where one of the American Indian reservations in South Dakota is located. So, it's very interesting. And also those two counties, the highest and the lowest life expectancy, are surrounded by counties of a different color. So even within a region, you can have these variations in life expectancy. Okay, and so to make it a little bit more local, a number of years ago, the Robert Wood Johnson Foundation created maps of various regions in the country to demonstrate, and they've been focused on social determinants of health for quite a long time, but to demonstrate how even within, in our case, the Hennepin and Ramsey County, that life expectancy varies. And they just happened to do a map of, this region. I don't know the backstory there. I used to live in Chicago, and they also did one in Chicago. So I don't know, it is very interesting to look at. But so you can see that, as you go from St. Paul on the right-hand side of this slide, and that white line represents Interstate 94, life expectancy varies. And you think about the different communities that, might be cutting across the interstate freeway there. And so you can think of the richer areas like, Woodbury and some other areas, and then some poorer areas. And so you can really see that place matters, and life expectancy really does vary in a very short distance. Okay, I think we can go to the next slide. So again, what accounts for these differences? We know that the leading causes of death, for example, heart disease, cancer, stroke, chronic lung disease, accidents, and diabetes, have significant lifestyle and behavioral components. We hear that all the time, right? You go to the doctor, you're a smoker, you're told to stop smoking. If you have excess weight, you're told to lose weight. So there's a focus a lot on these individual behaviors and lifestyle factors. But we also know that most behaviors are socially patterned. You have friends that smoke, you're probably more likely to smoke. If you live in an area that doesn't have access to quality fruits and vegetables, or quality grocery stores, you're going to be eating what's available to you, and so you might not have as high quality food. So essentially, what we've come to know by studying social determinants of health is that our health and well-being are dependent on the social context of our lives. Beth, your turn.
All right. So now thinking about then all of these determinants of health, this graphic gets at that. What determines somebody's overall health? As Sue said, often we think of behavior, which fits into this 40% of, do you exercise? Do you smoke or not? Do you get enough sleep? And we often also think of genetics. What's your genetic likelihood? Do you have good genes or not? Environmental exposures make up about 5% of these determinants. So that could be, whether you live in a polluted area, either polluted water or polluted air. And then healthcare delivery, which we pour a lot of resources into, actually only accounts for about 10% of a person's overall health. And that would be, the access to hospitals and access to primary care and all of that falls under healthcare delivery. And then this last 15% falls under social circumstances. If we look then at things from our social place and environment, so this social circumstances, our environmental exposures, and also behavior, because where someone lives, whether it's a safe neighborhood or not, may determine whether they can exercise, as you said, access to grocery stores, access to education. There's a lot of things that influence our ability to make certain behavior decisions. So if we look at this environment exposures plus behavior plus social circumstances, this means that at least 60% of our health is determined by where and how we live our lives, where we live, where we work, where we play, where we worship, where we sleep. And these altogether are known as social determinants of health. So to pause for a minute to review this terminology, social determinants of health, which is also called social drivers of health. These are underlying community-wide social, economic, and physical conditions in which people are born, grow, live, work, age. These are the causes of health and of social needs. So social determinants of health shape both individual material as well as psychosocial circumstances or social needs. And they also shape biologic and behavioral factors. So one example of a social determinant of health would be quality of schools. So education is linked to socioeconomic status, and both of these are risk factors for developing various chronic conditions and for lower quality of life and lower life expectancy. And so that is how we think about social determinants of health. On the right column, you see health-related social needs. So these are individual material resources and circumstances, either psychological or social circumstances that are required for long-term physical and mental health and well-being. And so if social determinants of health are the causes, then social needs are the effects of the causes. So, this might be whether somebody has housing, whether they have access to food, clean water, clean air, sanitation. And that the psychosocial circumstances might be stressors like negative life events or stressful living situations or not having social support, being isolated. So these are kind of in the moment needs that an individual would have. So an example of this that's related to quality of schools would be low health literacy. So this could be caused by not having quality schools. And this is the direct health related social need that somebody may need extra help understanding a disease process or how to take their medications or thinking about what resources a person might need to stay and be healthy. There's a third consideration that we won't discuss too much tonight, but just to also say it out loud is that a third thing kind of on top of all of this would be structural determinants of health. So these are the causes of the causes. So these are things like the climate, socioeconomic and political context of a place, really the structural mechanisms that shape our hierarchy in our society and equity. So if we think about social determinants of health, this is a figure that was put forth by the Robert Wood Johnson Foundation, and it sort of gets at the big picture of a very complex thing through a very simple schema. And so first, these health-related behaviors in the bottom and medical care are very important determinants that shape someone's health. But these things do not occur in a vacuum. Moving upstream, there are living and working conditions that can influence health both directly, for example, whether you're exposed to lead in water or if you're exposed to stressful experiences, or they can shape things indirectly, for example, shaping the health-related choices that somebody can make for themselves or their families. The diagram then highlights how health is shaped not only by living and working conditions, but then on top of that are also economic and social resources and opportunities. And this influences somebody's access to working conditions and living conditions that influence their behavior and healthy choices. So what are some of these factors specifically? This is a graphic from the Kaiser Family Foundation outlining some of these examples. So in this, under this column of economic stability, these are things like employment, income, how many expenses someone has, how much debt they have, medical bills, support. The built environment or the neighborhood and physical environment, things like housing, transportation, safety, parks, playgrounds, the walkability of a neighborhood. Education is very important. It affects a person's literacy, their language ability. Early childhood education is influential, vocational training and higher education. Food is another one. Hunger and access to healthy options really influence health. Community and social context. This is a sense of social integration, support systems, community engagement, discrimination that someone might experience living in the community in which they live. And then our healthcare system is also a social determinant of health. This includes things like whether somebody has health coverage or not, availability of clinicians or providers, whether a provider has linguistic and cultural competency, and then the quality of care that's provided. So we have a brief video that we'd like to show, and hopefully we can just get out of that. We'd like to show that kind of reviews all of this. Let's play this here.
I should really go to the doctor, but the closest office is an hour away. I can't take that much time off work.
Since I got laid off last month, I felt so stressed. I need to provide for my kids, but no one is hiring. I don't know what to do.
I used to know every single person that lived on my block. Now I don't even recognize the place. There's just no sense of community anymore.
When we talk about how to maintain our mental and physical health, we often focus on things like eating healthy and going to the doctor. But our health isn't just affected by the choices we make, it's impacted by our environment. The conditions in which people are born, grow, work, play, learn, and worship are called social determinants of health. Social determinants of health can be visualized as a river with two categories of determinants: upstream factors and downstream factors. Upstream factors occur at the systemic level. Examples include institutional discrimination and accessibility of education, employment, housing, healthy foods, and quality health care. Downstream factors are specific to individuals. Examples include employment status, level of education, and aspects of identity such as gender, race, and disability status. Just as building a dam upstream impacts the flow of a river downstream, upstream social determinants directly affect downstream ones. Consider race. In and of itself, race does not impact health. Rather, systemic racism leads to consequences like less access to employment and education, which in turn negatively impact health. To begin to recognize the relationship between social factors and health, consider these statistics. Suicide rates are highest in the Western American states and in Appalachian regions. Non-Hispanic Black individuals have the shortest life expectancy of any racial group, and the mortality rate of Black infants is more than double that of white infants. And as compared to people with an annual family income of $100,000 or higher, people with a family income of $35,000 or lower are 5.4 times more likely to experience serious psychological distress, but 10.6 times more likely to go without needed care due to cost. Tackling the social determinants of health, especially the upstream factors, can seem like a huge task, but we can all make a difference by advocating for change in our own communities. A good place to start is with the U.S. Healthy People website. This site has stated goals related to social determinants. which are aimed at improving the following. 1. Access to jobs, food, and housing. 2. Access to education. 3. Community connectedness and inclusion. 4. Access to healthcare and health literacy. And 5. Neighborhood safety and housing quality. Throughout this process, remember that systemic issues impact individuals differently, that people are the experts of their own lives, and that social structures won't change overnight. But with empathy and sustained effort, we can better the health of everyone.
All right. Switched around. All right. We wanted to just pause for a minute at this point in our talk for some brief small group discussion. So we want you to think about a health concern that you have about your community. Whether, I think probably all of you are from Hastings, I'm not sure how widespread you are, but think about something that's concerning you about your community. And given what we've talked about, what social or environmental factor can you think of that influences the health concern that you have? And then if there's time, talk about how might you encourage.
My wife and I had a small group of 2, and she was sharing with me, there's a project she's worked with our Hastings Family Service that as a volunteer provides rides for community members who need assistance getting to health or dental or actually are social appointments, people who don't have transportation or people who have to leave town and you can't drive out of town. And so that's a service to these people that had the volunteers not been available would have substantially and adversely impacted their health. And so that's a bigger systemic issue. That's a question about transportation, about poverty, about ageism, access, et cetera. Yeah.
Yeah.
Access,
Thank you.
I think
Is there
that's a really
public-
good one, Bill. And I did bring that up too. Like I have, I know someone who lives out in the like near the apartments and townhomes out off of Spiral Boulevard. And there's a young girl and she doesn't feel safe walking alone, you know, so she's in a spot. It's a nice spot back there, but then to be, say, walking home at night from a job or something, she wouldn't feel safe and she doesn't have a car. So then that becomes an issue for her. And she's a teenage girl.
Is there public transportation in Hastings?
Only at a cost.
yeah, I don't know if you could hear that. It's minimal and it's not free for most people and it's not very efficient. It's a dilemma of being an outer ring rather than an inner ring community. It's difficult to get good public transportation out here, or any, quite frankly, not just good, any.
Yeah, our group had that also, talked about the lack of the public transportation that can limit people the access to getting to maybe jobs or their health care, but also we live in what was described as a triangle between Prairie Island, Flint Hills, and Ashland. So we've got 2 refineries and Prairie Island that kind of form a little, you know, for people thinking about the health effects of that, along with farming and fertilizing. It's this farming area surrounding all of us. And I commented that I grew up in Cottage Grove and we always thought of Hastings as a party town. So and now I've worked in substance abuse, I've worked in all that, but that was in the 70s. That was the thinking. But there's some substantiation with that. And in our group that was brought up also that even parents would be known to make use of different substances when they're involved with their kids' games and things, hockey. So, I mean, it's everywhere, but Hastings has had a, has had a little bit of history, maybe having a little bit more problems along that line. So just one thing, some other things that we came up with. We don't think we had too many plans of how we could make that work or remedy, but just coming up with the ideas takes a while.
Well, right. And I think that, to the point, being a hockey parent, that's actually my only connection to Hastings, is having been there for hockey tournaments. You get kind of caught up in the social context. I mean, so you can kind of see how one social context, pressure to maybe drink at a hockey party might lead someone down that path versus, some other group that might have, different plans or that sort of thing. But I think having these conversations and starting to, expand knowledge about these factors then can lead to generating ideas about, some solutions or, things that can be made different to improve the social environment and hopefully impact the health of the community.
Great. Thank you all so much for sharing. We have a bit more to get through, so I'm going to keep, if there's anything else you'd like to share, please save it for the discussion at the end. Sue, I'll let you take over.
Back to me. So thinking back to those maps around life expectancy, I wanted to show you a few other maps. And so these are data on heart disease and stroke death rates in the US from 2015 to 2017. And I realized I didn't mention before, usually there's a 2 to 3 year lag between when we have the data to look at and, the current day. So that's why I'm showing data from, 2017, 2018. And we'll have a little bit more to say towards the end about how some of these data might look post-COVID, since that has certainly been in the news, and Beth has some interesting comments to share. But what I hope you can see in these two maps of the US, again, the counties are outlined on the maps. In the darker the color, the higher the death rate. And so we see that, and this is for adults ages 35 and older, you can see that the dark colors are still in that kind of southeastern part of the US with some darker colors and some other areas. But the general pattern is very similar between these two maps, as you can see. Next slide. These maps now show prevalence of low education. So this is the percent of the population without high school diplomas on the left, and the map on the right is the prevalence of percent of the population living in poverty. And so immediately what you see, of course, is that these patterns are very similar to the heart disease and stroke death rates, and then previously to the life expectancy maps, right? So you can really see that there are regions of the country where, in this case, the proportion of people with lower education and the proportion of people living in poverty are higher, and consequently, their death rates are higher and their life expectancy is lower. So for me, these maps have always been very effective in just kind of very clearly showing the patterning. And that's what we're trying to get at with, part of this presentation this evening, is really the patterning of these social and environmental factors and how our disease rates and life expectancy map onto those. So the next couple of slides are put up just to make a couple of points. So the AHA is the American Heart Association. So it's probably the premier organization in the country focusing on heart disease. And then they have a sister organization, the American Stroke Association. And in 2015, Dr. Havranek and colleagues published this scientific statement. And so the AHA puts out scientific statements to inform not just the members of the AHA, but the public at large on important health topics related to heart disease and stroke. And so they put out this statement on social determinants of risk and outcomes for cardiovascular diseases. They stated the purpose of the publication was to increase awareness of the influence of social factors on the incidence, treatment, and outcomes of CVD. Again, CVD stands for cardiovascular disease. And within the paper, within the statement, they present a lot of evidence that links socioeconomic position, race, ethnicity, social support, culture and language, access to care and residential environment to various CVD risk factors and outcomes. And what they conclude with are several recommendations, including continued research on social determinants of health, especially the impacts of social disadvantage. And I mean, to your point that you made early on, Bill, when we started, creating linguistically and culturally appropriate care for CVD risk conditions. In the statement, they mentioned diabetes specifically. So really powerful that this premier organization recognizes the importance of social determinants of risk and outcomes. Funny story, in 1997, I made a presentation at one of the AHA conferences, and I had been doing a study looking at various emotional factors. And there was a group of men in this study we identified as having high levels of anger, and they were significantly more likely to have a stroke over the follow-up period of the study. And I had never presented to a group of cardiologists and neurologists before, and so I had this presentation. And the question I got was, well, should I put all my male patients on beta blockers, like a particular medication, because that might stop them from being angry? And I just looked at the person, I thought, well, first of all, I'm not a physician, I can't answer the question, but he couldn't even grasp the idea that there were, personality factors and, life experience that led to some of these emotions that could be driving this relationship. He wanted to go straight to just put the person on a pill to fix it. So, that was in 1997. Many years later, this premier organization is recognizing these important factors. This paper was actually published just in January. It was available online a month or two before that. And it's a wonderful paper. It summarizes current and, I would argue, compelling research linking these social determinants of health to diabetes risk factors and outcomes and care among adolescents and adults, and it addresses both type 1 and type 2 diabetes. It focuses on 5 of the social determinants of health categories: socioeconomic status, neighborhood and physical environment, food environment, including access to food, to healthy foods, and food insecurity, healthcare, and social context. And they state 5 important recommendations for future research, including one that caught my eye, and that is prioritizing the next generation of research that targets social determinants of health as the root causes of diabetes inequities. This, again, is a 2021 publication. So it's really important that these national organizations, and I should say this was published in Diabetes Care, which is probably the premier scientific journal focusing on research and care and treatment for diabetes. And so these 2, major organizations have put this out, yet, Beth, next slide. We also want you to know that it was actually nearly 75 years ago that the World Health Organization put this statement out defining health as follows: health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. That was in 1947. It was the World Health Organization, which in many ways has had much more sway in other parts of the world and less so in the US. Oftentimes when we give these kinds of presentations or, talk to groups, we'll ask people just to define health before we put up this kind of definition. And invariably, people will mention, the importance of, relationships in your community. And so people understand that, I think, at a kind of intuitive level, especially now. But here, the World Health Organization 75 years ago was making this statement. And these, premier medical organizations in the US, at least, are catching up. But we're hoping that there's even more widespread understanding and recognition of these factors moving forward. Beth?
I have to unmute myself. Thank you very much. So we did want to spend a little bit of time today talking about COVID-19, since that has consumed our last year of our life. And really, COVID-19, as you've probably read and seen, has exposed the social factors that determine health in our society. And so one of the ways we see inequity is by race. And this virus is certainly exacerbating Minnesota's racial disparities on many fronts. So it exposes really that systemic racism is still here and persists. So this is a table, a graphic that looks at the incidence of COVID-19 for 100,000 residents by race. You can see at the top of this graphic, it says it's age adjusted. So I just wanted to stop for a second and talk about what it means to age adjust. So age-adjusted rates allow us to compare rates for groups that have very different age distributions in Minnesota. For example, in Minnesota, our population that's 80 or older, 95% of them are white, and only 5% are non-white. But if we look at Minnesotans who are 30 to 39 years old, for example, only 66% are white and 34% are non-white. And so age adjustment essentially allows us to look at what rates would be if the underlying population distribution was the same for all age groups. And because COVID-19 affects ages differently, for example, we know that younger people have more asymptomatic and mild disease, and there's more severe deadly disease in old people. Considering age is really important. So what we're seeing in this graph is the highest incidence of COVID-19, which are new diagnoses, by race is among Native Hawaiian and Pacific Islanders, followed by the Latino ethnicity, followed by Black, and then multiple races. And in this, white and Asian are the lowest. Why is this? So one reason is that communities of color and Indigenous communities have increased exposure to COVID-19 because of work in low-paying jobs that are considered essential. So jobs that can't transition to working from home. So one example of this work is work in meatpacking plants. I'm sure you've seen plenty of headlines and stories about outbreaks in meatpacking plants over the past year. If we think about a meatpacking plant, if you have ever thought about that or know them a little bit better, social distancing is virtually impossible in a modern meat plant, which makes it an ideal environment for a virus to spread. So in recent years, at a policy level, meatpacking companies have successfully lobbied regulators to increase line speeds, or how quickly the meat passes. And so that results in workers having to stand really shoulder to shoulder to cut and debone animals to be able to work fast enough. And these machines that move the carcass along are often very loud, and so people need to shout to be heard, which we now know helps COVID spread. And so this is an example of policy that has influenced working conditions that during a public health emergency of an infectious disease influences the health of workers. We add to this the fact that many meat plant workers are immigrants who may live in crowded conditions with little or no access to healthcare. And we have a population who is really at very high risk for infection. Now let's think about COVID-19 and COVID death rates. So this top figure is death per 100,000 residents by race and ethnicity. Again, age adjusted to allow us to essentially look at what this death rate would be if the underlying population distribution in the state was the same for all racial groups. And the highest death rates are among Latinos, followed by American Indians and Alaska Natives, followed by Black Minnesotans, and then Asians, and then finally whites with the lowest death rate. And so how do we interpret this? Out of all residents in Minnesota, Latinos are dying at the highest rate, or the largest proportion of the Latino population has died from COVID. The bottom graph represents the percent of COVID-19 cases that have led to death. So here, American Indian and Alaska Natives are the highest, followed by whites as far as death rate. So why is there this difference between these graphs? This bottom graph really looks only at those who have confirmed COVID cases, and it's not adjusted for age since we aren't trying to be representative of the population. We're just looking at actual positive cases. And this difference is really because whites in Minnesota are disproportionately older, and because age is associated with severe disease and death, and we've had outbreaks in nursing homes where the majority of the elderly are white because that's who survives long enough into old age in Minnesota. So essentially what these graphs tell us is that way more non-white people in the state are getting COVID and then dying from it. When white people do get COVID, they tend to be old, and so it is more lethal for the cases of COVID. But big picture is that communities of color and Indigenous communities have substantially higher rates of health inequities, probably from risky work conditions to having social factors that contribute to higher rates of chronic disease that make COVID more severe. And these things make them more susceptible to getting infected in the first place, and then more susceptible to dying from COVID-19. So we already know from what Sue told us earlier is that there's a life expectancy gap in the US. And we are seeing that this is becoming even bigger because of COVID. So just from the first 6 months of 2020, life expectancy in the US dropped by a full year. And this is really staggering, and a glimpse of the cost of the first surge of the COVID pandemic. So even a few months loss is huge when we look at the entire US population. And so, losing a year of life expectancy is a big deal, especially over a 6-month period. But again, this decrease in life expectancy is not equal across races, which again reflects the magnitude of our racial inequality and higher rates disparities. So while life expectancy of a white man dipped about 0.8 of a year, right here, and the first 6 months of 2020, 3 years were taken off the life expectancy for a Black man. In 2019, the Black-white life expectancy gap had shrunk to only about 4.1 years difference between white and Black, with whites living longer than Black people. But just after 6 months of COVID, this gap has expanded again to 6 years, depending on whether you're white or Black. So what we see with this is more than ever, unless we see these disparities as acceptable, we have to focus on health equity to try to change things. So what can we do? So let's consider COVID vaccination. We are off to an inequitable start at the beginning. So the light blue line here is the race and ethnicity of vaccinated people, and the dark blue line is the proportion of Minnesotans from each racial category. And across the board, the race and ethnicity who are vaccinated is lower than that population in the state, except for whites, which is at the bottom. Whites represent 81.6% of the population, but almost 91% of those who are vaccinated. So what can we do about this? Perhaps we can base some of our vaccination efforts in ways that overcome some of these social barriers. And just about a week or two ago, the state said that they want to work on this. Some of the things that were announced: the federal government shipping vaccines to Brooklyn Center, which is an area that really is intended to target racial and ethnic minorities. The health department plans to deploy mobile vaccination units to several state agencies to deliver those vaccines to hard to reach communities. Even today in my clinic, I work at a community health center that's in a really diverse low-income neighborhood in Minneapolis, where we have a large immigrant population, including the Somali population. And some imams from the Somali community gathered to receive their vaccinations in our clinic, and they brought a Somali TV station to video them, as well as conduct some very brief interviews with clinic staff about why they received vaccines. And the goal then is to use this messaging and this religious community to bring the vaccine acceptability and information to that community. The goal then is to do some mobile units in the Somali community to help vaccinate them. And if we think about how people are getting vaccinated in our state, if you have barriers around transportation or accessing sign-up websites for those with limited English proficiency or don't have good internet access, or by, these are all social factors that contribute to who's getting vaccinated. Now, how do we address social determinants of health? What do we do about this? To change our community's social and environmental realities, really that often takes policy changes at a system level. Certainly people can, volunteer their time and energy to, you can imagine some changes in the community that might be helpful, but the vast majority of changes really come through policies. And we may be in charge of policies ourselves if we're a government leader, or if we're, I work in a healthcare system, so the leader of a healthcare system may be able to work on these policies, but otherwise we have to do this through advocacy. So a couple of last thoughts on advocacy. So I'm part of an organization called Minnesota Doctors for Health Equity, and the mission of our group is to educate health professionals to work toward health equity. And so we focus the majority of our efforts on teaching about how to advocate and around equity issues. And so we use this framework for thinking about how to advocate for changes in our communities, which I think is useful. So looking at the individual level, system level, community level, and then governmental or legislative level. So at the individual level, this is how are we as an individual engaging in our community. This is things like voting, where you choose to spend your money, what banks you, where you do your banking, where you do your shopping, you know, where you spend your volunteer time, you know, your resources and your time are important, and that's one way to you know, support things that can promote more equity in your community. You know, thinking then about what system you are a part of, and for many of us that might be a system that we work in, and for me that's a healthcare system. And so think about what you're doing to drive your system toward ideals that you value, and how you think about, you know, from my perspective in a healthcare system, what is the system doing to promote equity, not only for patient care, but in how they hire people, how they pay benefits, you know, who's getting benefits and who is not. And, you know, thinking about how the systems that you're a part of are doing these things can really have an impact when we think about the upstream causes of good health, some of those social factors. And then if we think about our communities, you know, a community can be your town that you live in or your city, but there are many other ways to think about community. It could be your religious community, your professional community, but you can certainly become a community organizer and work to change things in your community. And then finally, you know, the thing we often think of with advocacy is the legislative advocacy, and, you know, working to change policy through government. And so one thing one way to focus this is to use a health equity lens. So if we're thinking about how policies influence social determinants of health and health equity, it's examining every policy that comes up for what its effects could be and even unintended consequences. And this is not just, you know, our state senators making policy changes at the national level. You know, there are cities have ordinances, city councils pass those ordinances, and mayors sign those ordinances. So things that are happening at your city level can be very important. There are, you know, tobacco ordinances. Tobacco 21 has passed in some, you know, cities and counties. At the state level, you know, bills are authored and then introduced and given a hearing, and your representatives want to hear from you. They don't often get phone calls and letters and visitors from people who are on the ground. And if you call and you know, reach out and try to engage, that is often heard, especially if you have some kind of you know, specific knowledge about an issue. So these are all, you know, every level of government has potential for advocacy and helping to promote change. All right, Sue, I'll let you finish
So this
up.
is our closing slide. Just a reminder that our goal here in terms of talking about these issues is really to push towards health equity. And that's achieved when every person has the opportunity to attain their full health potential, and no one is disadvantaged from achieving this potential because of social position or their socially determined circumstances. And we like this figure, which shows, you know, equality doesn't mean equity. And so you see the shorter person trying to reach the healthy apple, and they all have equal size blocks boosting them up, but it does no good for this person. Whereas equity is really meeting the person where they are, getting them the supports that they need so they too can live a healthy life. So we'll close with that. And looks like we have about 15 minutes or so for Q&A. Happy to take questions. If you unmute yourself, or if you want to put it in the chat.
Well, Sue, I'll start off and just ask a question for either of you. rightfully so, most of your focus has been on issues related to things in Minnesota and the United States. But my question for you is, are social determinants of health a unique phenomenon to this country, or do they occur in other wealthy, developed nations around the world? And or maybe it's a way to phrase it is, I suspect they occur, but is there such a gap and disparity in other nations as there is what we've seen in this country?
That's a good question. I can start, Sue, and then please jump in. Social determinants of health are at play worldwide, but the kind of intensity of these disparities certainly differs. And I would say that it often maps onto the divide between rich and poor. I think that's often a really close link with how big the disparities are in health. A lot of other rich countries like the US have free healthcare. They see healthcare as a right, not as something that's a privilege that you get if you're employed. And so I think that is one piece that helps a lot with diminishing disparities. As we know, if you can remember from early on, healthcare access is not everything for determining our health, but at least that minimizes or makes that barrier no longer there. But certainly, there are countries in Latin America with a very large rich-poor divide. Some African countries. There are social factors at play worldwide, but the influence they have on health outcomes and the disparities between people living in a country really map often very closely to the divide between rich and poor. Okay.
Yeah, and I mean, just to, I guess, jump in on that, some of the earliest work that showed these, the social gradient in health, as it's called, actually came out of the United Kingdom. And Sir Michael Marmot was the lead researcher doing that work. And they have this, what's called the Whitehall study of civil servants. And what they found kind of unexpectedly was that those that had it wasn't just that people at the highest level of employment or civil service in this case had better health than those at the bottom. There was this gradient along the way. So those at the top were better than those at the next level, and those at that level were better than the ones just beneath them. So they really documented this gradient. And a lot of other countries don't have as stark of income inequality. So the gap between the rich and the poor is much smaller than in the US. And because of the history of racism in this country, which is really, I mean, I think now people in that short video we shared with all of you, one of the points that was made that wouldn't have been made not that many years ago was that, race itself doesn't lead to differential health. It's the structural racism. And so there are some unique things about the history of the US that have probably exacerbated the impact of some of these factors. And then also, other countries have more equitable policies, right? They have a better social safety net. And so the impacts aren't quite as great.
Thank you. Other questions?
I have a question. Oh,
you go ahead.
sorry.
Please, go ahead.
Okay.
Go ahead.
I just have a question with back when we were talking about the life expectancy for this country for states, that Hawaii had the highest. So it just seems kind of odd that also they have the highest case incidence for the COVID.
Question. So the data that I showed is just Minnesota. So those are Hawaii, Pacific Islander populations who live in Minnesota.
Okay.
And so that it probably is that they're, that population who's living here in Minnesota maybe looks really different than the population who's living in Hawaii would be my guess.
All right, just caught my attention.
Yeah, that's
I
a
was
really-
thinking, okay, what happened there?
That's
I
a
need to
really
go back to
good-
Hawaii,
good catch.
live on the island.
Never been there, but now I'm wondering if no. All right, thank you.
Yeah.
And I think it would also suggest that it's more of clarity, that it's the social environment
Sure.
that
Yep.
causes the health disparity rather than the physiology of any individual subset of human population.
It's not the genetics.
Yeah.
It's the social context. Yeah.
I remember a number of years ago, there was an interesting report about, I'm trying to remember, I think it's gastric cancer was particularly low in, I believe it was in the Japanese population, but Japanese Americans, gastric cancer was particularly high. And when they began to explore, it had to do with the way food was prepared. And they may have it backwards, but the notion, at least for me, was populations of the same genetic populations in different social environments have totally different expressions of their healthcare and the morbidity and mortality that's exposed to it, which is an indictment of social environmental impact. Maybe indictment's a strong word, but that's how I feel that way. Yeah.
Oh, I think that's right. And I mean, you can think of your, DNA or your genetics as, potentially predisposing you to a particular condition, right? I mean, in my family, it's diabetes and heart disease. And then the social environment is going to be, does that flip that light switch on or keep it off, right? And so there is definitely kind of a person by environment interaction, if you will.
Right. And Beth, I want to thank you for answering these questions online about the studies that people are asking for. Thank you for that. All right. If any other questions or comments?
Question.
Yes.
I'm just curious. So, and maybe I'm misunderstanding your role within the university organization, but I thought it was really interesting, one of your comments at the beginning where you talked about don't show me in your beliefs, show me in your budget.
Mm-hmm.
I think that's really important. And so I'm just curious, how do you feel supported, or how do you feel that the university healthcare system is adopting that and these ideas and these concepts? Do you feel it's supported?
So the Program on Health Disparities Research is a group of, faculty and staff, and we also have community members as well. And so we try to embody that value as we function as a unit within the university. I would, I guess, be naive to think that the whole university operates that way. I can't speak to the clinical side of things since I'm not a clinician, but I think there is growing, I don't know if I want to say just attention, because it's not just attention. There's growing action around promoting health equity at the medical school at all levels. And I know actually just today, our Department of Medicine announced, a new high-level administrative position, a person named to be the vice chair for diversity, equity, inclusion. And so the idea is to be more action-oriented, and hopefully people have their budgets aligned with their values around equity. But it's a slow process to change some minds and change some hearts, for sure. I don't know, Beth, if you want to speak to this, working at the Community University Healthcare Clinic and how you guys operate, if you have access to that information.
Well, I was just about to say, I think it's really opaque. I think that, the university is, even just looking at, we're both within the medical school of the university. And I think it's really hard to get that information. I would say that I feel like the medical students and young faculty and staff seem to be care about that a lot and are really thinking about advocacy. I think that a lot of times students do a lot to try to push this big behemoth institution toward more equity, but it takes a lot of legwork, and I think it's really hard to change these systems that have been in place for a really long time and where there's not much transparency.
But we do have a pretty amazing president at the university, Dr. Joan Gable.
Yeah.
She has she is a really strong leader, and she's very communicative. And I feel that she has been more transparent in her decisions and how they're pushing things, just broadly speaking, around the university in a way that I hadn't seen in the decade prior to her being there. So there is progress.
Yes, and I think certainly with George Floyd's death and this pandemic, and there's been a lot of things that have come up that I think she has really handled well.
Yeah, just today she sent an email out acknowledging that we stand with our Asian and Asian American students and staff after the tragic killings in Atlanta. So there was no delay. I mean, right away there was a message out, not only professing solidarity to those groups, but also then providing lists of resources for people, mental health resources and other resources, and encouraging faculty to recognize that some of their students might be really traumatized by this, and so to accommodate them. So that kind of sensitivity wasn't at the U previously, in my experience.
I have a question.
Mhm.
So it's kind of a two-part question, or not two-part. First, the question is, I know that about a few years back, no, not Robbinsdale. I might have the wrong school, but the high school put together a health clinic resource within the school so that the disparities and inequities, because the majority of that population were minorities and people of color and people from marginalized identities. And I'm curious if because we pointed out in the very beginning of your presentation about education and access. And so do you know of other schools that, or if that's gonna be something that happens where there will be access and information combined with schools? Do they have it? Are you aware of that program that they have?
Unfortunately not.
Okay.
I don't know, Sue, if you...
I'm not aware of the Robbinsdale program specifically, but I'm aware of other school districts that do have kind of expanded nursing clinics, if you will. I actually have a friend who's a master's trained school nurse in a Colorado school district. And I remember years ago her telling me that they had kind of expanded office hours, if you will, to help meet the need of the community that she was working at, the school where she was. And so there are other schools that provide that. The other example, so I think if your question is, if you're in a lower resource setting, or, can you lean on school systems to provide some of those services?
Mm-hmm.
If that works for a community, I think that's a great idea.
Okay. But that's not something that's out there in a wide range, because I've only heard of 2 systems in Minnesota that have done it, and I don't know. So my curiosity was if there was any research on the effectiveness of that.
Oh, I'm not aware of any research on
I haven't seen
that.
anything either.
Okay.
But the other kind of schools that serve a social need, the other issue is around food insecurity. So especially during the pandemic, we've all heard of schools that have maintained their nutrition programs and either had pickup locations or been able to drop off food for families that where normally the kids would be eating at school. And so communities I think are trying to meet those needs, certainly more than they used to, but there is a recognition of those needs.
Great. And then the other question is your slide deck available at the U of M, or do you not make your slide deck available as far as the resources and the information?
Oh, we can make it available.
I'd be happy to share it.
Yeah. That would be great.
Bill, do you want to tell us how best to do that?
Yeah, and I think probably the best thing to do would be to send it to me, Sue.
Okay.
Robin, also, I should just tell you that this is being recorded, and we will have the entire program up on the Thrive website and Facebook shortly. I'm sorry, I can't give you a definite time, but in that context, you'll be able to see the slides too. But yes, if you'll send the slide set deck to me, I can make sure it's available to us. And probably, if it's okay with you, with credits, we'll put it on our Facebook or website page rather, so that people can look at it. But I'll be sure courtesy.
That's fine.
Mhm.
Thank you.
I want to make just one more comment about education, because I don't think we can undersell the importance of education in all of its varieties. Oftentimes it's easy to focus on going to the educational institutions like the school systems, but the impact of people's, I think you talked about the word health literacy, is being shown in what we're seeing now in problems with vaccine acceptance. People are getting education from multitude of sources that are not giving valid or reliable, or quite frankly, even truthful information about the disease, about the vaccine, about its side effect profile. So education is a more expansive language, I think, than just what goes on in the schools, and we can't overlook that in this disparity question.
That's a really great point.
Mhm.
All right, I really appreciate this, both Sue and Beth. Thank you so much for doing this. It's just been wonderful, and we look forward to hearing more about this. And then perhaps as things unfold, there's an entirely good possibility that we might be calling on you to answer some other questions for us. But thank you for both of you for your work that you're doing in this, and makes me wish I was still practicing medicine again to go back and explore these things. And for all of you who joined us this evening, again, thank you. And as I said earlier, we will have this up online, and it will be available for people to view.
Yeah, thank you. It was really fun. I appreciate that you were engaged and asked questions and shared. That makes it fun for me to participate. So thank you.
Yeah, I really had a good time too. So thank you for inviting us, Bill.
Well, thank you. It's our pleasure. Great to have you.
All right. Have a good night. And we'll get those
Good
slides
night.
to you.
Everybody else be looking for our next event. And thank you and good night. Please be
Good night.
safe and be well, everybody.
Good night.
Thank you.
Thank you very much.
And Carrie and Derek,